Hi everybody, welcome to my e-learning. My name is Marloes Derks and I'm a fourth-year medical resident becoming a medical oncologist. And I've been doing my PhD in breast cancer treatments in older patients. And today I would like to talk to you about treatment of older patients. And to me, this is all about balancing between under and over treatments. So let's get started. So after this presentation, you will be familiar with outcomes in older patients with breast cancer, what kind of variation there is in the treatment of older and younger patients, and how this is also varying across several countries in Europe, and what we would call overtreatment and undertreatment, and how we can optimize our treatment strategies for our older patients by making use of our prediction tools. So if you look at the survival outcomes of older patients with breast cancer, you can see that the survival in the relatively younger group, so those patients aged under 75, has been increasing over the last years. But unfortunately for those patients aged over 75, breast cancer survival is lagging behind. Not only do they experience a poorer survival outcome, we also know that physical functioning and physical activity after breast cancer diagnosis is decreasing among the oldest population, and it does not recover after treatment. So they also experience poorer physical outcomes. So some of the reasons for poor outcomes are that we have limited evidence of how to optimally treat older patients. And because we don't have enough evidence, we have no specific guidelines for the treatment of older patients. And this leads to variation in treatment and puts patients at risk of undertreatment and overtreatment. As I said, we have limited evidence of how to treat our older population. We know that patients who are older are actually representing a large proportion of patients with cancer. But unfortunately, only a small group of those patients are included in randomized controlled trials, as you can see in this graph. And if we look at those patients who are included in our randomized controlled trials, they are physically more healthy compared to the general population. They have a higher socioeconomic status, have less comorbidities, and therefore they do not represent our older general population. And this is limiting us in the external validation of the results of the randomized controlled trials. So we don't know if those results that we achieve in randomized controlled trials are actually feasible for our older population. So I would like to take you through some basic principles of breast cancer therapy for the general population. So local therapy consists of surgery, and the surgery is defined by the size of the tumor. If you have a small tumor, the surgeon will resect only the tumor and its resection margins, and this is followed by radiation therapy. If you have a larger tumor, the surgeon will resect the complete breast tissue, and because of all the breast cancer, the breast tissue is resected, it's not followed by radiation therapy. And in case you have positive lymph nodes that has either been found by the diagnostic workup or by the sentinel lymph node procedure, those lymph nodes will be resected or they will perform radiation therapy on the axilla. If you look at systemic therapy of early breast cancer, it's slightly more complicated. It very much depends on the type of tumor that you have. So if you have a luminal-like tumor, which means that your tumor is hormone receptor positive, you will receive adjuvant endocrine therapy for 5 years. And this is started after local therapy has been performed. If you have a tumor that is triple negative, meaning that the hormone receptors and HER2 are negative, you will receive neoadjuvant chemotherapy, which means that chemotherapy is started before local surgery. And if your tumor is HER2 positive, you will receive trastuzumab and or pertuzumab, depending on the type of tumor, in combination with endocrine therapy if you are also having a hormone receptor positive tumor. So if we look at treatment in the older population, you can see in these graphs that there's a large variation only by age. So with the increasing age, you see that the number of patients receiving surgical treatment is dropping very steeply. And those patients who do not receive surgical treatment do receive primary endocrine therapy, as you can see in graph B, which means that they do receive endocrine therapy, but they do not get surgery. Also, you can see that the number of older patients receiving radiotherapy after breast conserving surgery is dropping with the increasing age. And this is also the case for those patients receiving axillary surgery in patients with positive lymph nodes. And you can see that also the proportion of patients receiving this type of surgery is declining with age. There is not only variation in treatment between patients' age groups, but you can also see that there's a lot of variation between several countries. And in this study, we have included over 200,000 patients from 5 different European countries. And these patients were aged 70 years and older. And if we look at patients with stage 1 breast cancer, which means a small tumor with low grade and no lymph node involvement, you can see that there is variation, especially among starting endocrine therapy after local surgery. You can see that in Belgium, around 86% of the patients receives endocrine therapy, while in the Netherlands, this is only 18%. And if you then look at the right graph, which is showing us breast cancer specific survival, and then the relative excess risk of that, which is comparable to hazard ratios, you see that patients in Belgium and in the Netherlands have similar relative survival outcomes, so similar breast cancer survival outcomes. So apparently there is no difference in outcomes in those patients receiving, in those groups receiving endocrine therapy compared to those groups with only low amount of people receiving endocrine therapy. So this might be suggestive of overtreatment. And oh, there's a blur in my presentation, but I just ignore it. As you can see, this is explained by a variation in guidelines. In the Dutch guideline, which is independent of age, we do not prescribe adjuvant endocrine therapy in patients with low-risk breast cancer, which means small tumors with low grades. While in all the other international guidelines, every patient receives endocrine therapy for a period of 5 years or longer. If we then look at radiotherapy after breast conserving surgery, there has been a very nice randomized controlled trial in 2015 that included patients aged over 70 years with a low risk type of breast cancer, so a small tumor without lymph node involvement. And all these patients received endocrine therapy for 5 years. And these patients were randomized after surgery in receiving radiotherapy or no radiotherapy. And as you can see in this graph, the number of recurrences in the same breast is really low in both groups. So we can say that there is no additional benefit of radiotherapy in this patient group. So starting radiotherapy in patients with low risk breast cancer might be giving overtreatment to these patients. So in our recently updated guidelines for all the patients, or technically not guidelines, but only recommendations, we do not recommend radiotherapy in those patients with low risk breast cancer. If we look at patients with a more advanced stage of breast cancer, which means a larger tumor with lymph node involvement, we can also observe a large variation in breast cancer surgery among different countries. So in Belgium, approximately 80% of the patients does receive surgery, while this is only half of the patients in Ireland and England. And as you can see in the right graph, there is a higher risk of dying due to breast cancer among patients in Ireland and England. So this might be suggestive of overtreatment to omit surgery in large groups of patients. And this is a recently published study by the group of Linda Wild in England. This has not been a randomized controlled trial, but if you look at the left graph, you can see that those patients receiving surgery have better overall survival compared to those patients receiving primary endocrine therapy. However, probably those patients receiving primary endocrine therapy have been selected because they do have a poorer life expectancy, a poorer health status, more comorbidity. So they are at risk of dying. They are at higher risk of dying compared to those group of patients who did receive surgery. If you look at the breast cancer specific outcomes of these both groups, you can see that those patients receiving primary endocrine therapy after a period of 4 to 5 years, they do experience a poorer breast cancer specific survival. So maybe that might be caused by giving primary endocrine therapy only. So the recommendation for primary endocrine therapy is that you can only start this when patients have a very low, when they have like a very limited life expectancy of less than 5 years. So this should only be considered in those patients. So this is what it's all about when you are considering starting a type of therapy for patients. If you look at survival, you will look at two things at the same time. On the one hand, you look at breast cancer specific survival, so the risk of dying due to breast cancer, while on the other hand, you look at dying due to other causes. And the extent of your breast cancer risk versus the risk of dying due to some other causes is going to define the extensiveness of your treatment. The risk of dying due to breast cancer is mostly based on breast cancer characteristics. So the grade of the tumor, the size of the tumor, lymph node involvement, they all define the risk of dying due to breast cancer in the future. While on the other hand, dying due to other causes is mainly defined by the type of comorbidities, physical functioning, cognitive functioning, nutrition status, and that is what we call geriatric characteristics. And making up the balance between dying due to breast cancer versus dying due to other causes will help you selecting the right treatment options. So if we look at the role of comorbidities among older patients, you can see on the left side in older patients aged over 70 years, that the number of comorbidities is predictive for dying due to other causes, but not for dying due to breast cancer. And if you look at some other geriatric parameters, you can see that the MNA, which is a representative of the nutritional status, the GFI, which is saying something about somebody's functioning, and also a sum score of various geriatric parameters are very much predictive for dying due to other causes than breast cancer. So as I said, we need to optimize our cancer therapy, and therefore we need to include both geriatric parameters and breast cancer specific parameters to define which patients are very frail and should only receive supportive care, and which patients have a high risk of breast cancer and both have a low risk of dying due to other causes. So those patients will benefit the most from the most extensive type of treatment. And to be able to define those patients groups to a better extent, we can use prediction tools. And one of the most well-known prediction tool is the prediction tool, which has been developed for all patients with breast cancer, so not specifically for all the patients. And in this prediction tool, you can predict 10-year overall survival, and it includes mainly breast cancer specific parameters. And it will help you to predict the risk of dying risk of dying and the additional benefits of surgery, endocrine therapy, and chemotherapy. And in our study group, we have been validating this prediction tool for our older population. And as I said, there were no comorbidities or geriatric parameters included in this prediction tool. And what we saw is that the predict tool overestimates the benefit of the treatments for older patients because they do not take into account the risk of dying due to other causes, and they do not take into account comorbidities or other geriatric parameters. So very recently, the group of Linda Wild published a prediction tool that was specifically designed for older patients with breast cancer. And as you can see in the upper bar, it includes both age, some tumor characteristics, but also comorbidities and some frailty parameters. And it will help you predict the risk of dying due to breast cancer and the risk of dying due to other causes. And as you can see here, this prediction is for surgery versus primary endocrine therapy. And they've made a very similar tool for estimating the benefits of surgery and chemotherapy versus surgery alone. And you can see that it can help you further defining the additional benefit of chemotherapy. And this will help you in talking to patients about which type of therapy would be suitable for them. And very recently, our own research group has published a prediction tool called Portrait, also for older patients with breast cancer. And you can read about the publication in the Lancet Healthy Longevity. And also we have made a YouTube video which will explain you more about our Portrait tool, and you can use the link to find the YouTube video. The tool will be launched really soon online, and it will also be available in English. And it predicts the recurrence of breast cancer and death due to other causes. And it will help you estimating what will be the additional benefit of endocrine therapy or chemotherapy. And this will also help you further in communicating with the patient, with your patient, which therapy will be the most beneficial and which will suit the needs of your patient. So if you would draw some conclusions, I would recapitulate which patients are most at risk for undertreatment and which patients are most at risk for overtreatment. So those patients at risk for undertreatment are those patients with a very long life expectancy and a low risk of dying due to competing mortality, because they will benefit most from adjuvant therapies. Also, those patients with a high risk of dying due to breast cancer, with, for instance, a high stage of breast cancer, they will also benefit most from more adjuvant treatments. And patients receiving primary endocrine therapy, when they have a reasonable life expectancy, they are at high risk of undertreatment. On the other hand, patients who are very frail and they have a low life, so they have a high risk of dying due to other causes, will not be likely to benefit from adjuvant therapy. So they are at risk of overtreatment. And the same goes for patients with early stage breast cancer, because they have a low risk of dying due to breast cancer due to the low stage of their disease, and they will not benefit that much from adjuvant therapy, such as adjuvant endocrine therapy and adjuvant radiotherapy. So I have some final suggestions for further readings. First of all, I think it would be very helpful if you would use some of the tools just for some imaginative cases, but it will show you very nicely what would be the benefit of several adjuvant treatments and what would be the outcomes of those patients. So you can just use them and play around with them and maybe learn a little bit more about outcomes for older patients. Furthermore, we have a recently updated recommendation guideline, which was published in the Lancet Oncology very recently. And Nienke de Glas, one of our fellow researchers and a medical oncologist in training, she has her own YouTube channel in which she discusses the use of prediction tools in further detail, but she also has some more videos on breast cancer and other types of cancer in older patients. So please feel free to watch those videos as well. If you have any further questions, I would be happy to help you further. So send me an email, and I hope you have enjoyed watching this video.